Okay.
This is Caitlin, I'm Belinda. We're intern pharmacists, which means we're our first year out of uni, and we have to complete an internship over the year, just before we are granted with our general registration. So we've got someone sort of watching our back for our first year, which is kind. We're going to be talking to you about medication treatment in AS. Full disclosure though, we're not specialists, we're just pharmacists. So your specialist might have told you something different to what we might tell you today. That comes to them. We're just highlighting the main treatment options that exist. But again, everybody's different and there are specifics. So just take it with a bit of a pinch of salt. But yeah, we'll just highlight the main stuff.
I suppose we'll start with an acknowledgement to country. So we acknowledge and respect the Bangala people and the traditional custodians of this ancestral land. We acknowledge the deep feelings of attachment and relationship of Bangala people to the country and to the sea.
A little bit about us. So my name is Belinda. I grew up in Malang, which is a small town of about 500 people near Strathalbyn. I graduated at the end of last year from the University of South Australia and have commenced my internship at the Port Lincoln Hospital. I'm super passionate about the wellbeing of the community, so it's great to be able to talk with you guys today.
I'm Caitlin. I grew up in Wales and I'm currently completing my internship at Priceline in Port Lincoln. And I suppose I'm just passionate about making healthcare accessible to all and making it available to everyone who needs it whenever they need it.
So we'll be talking about what is ankylosing spondylitis, which I'm sure you're all well aware, but it's an inflammatory arthritis that particularly affects the spine. It is prevalent in the EP, more prevalent than...
Why is it?
I would love to know, but we are told that there is a higher level of incidence over here. So it's great that there is a community group for support.
There is?
Yeah. This is what we're in right now, the community support.
Okay.
Yeah. We want to treat it so we can, prevent disability, manage pain, and just, promote quality of life as well. We want, to live as pain-free as possible, and there's treatments that can definitely aid that.
I suppose we'll start now with some of the treatment options. So first we're going to sort of what a brand name is and what a generic is, because sometimes that can be confusing for people if they've been given one brand their entire life and all of a sudden that's out and they've been given a generic and they think, what is this?
And the tablet's the wrong shape and
exactly,
size and colour.
wrong shape, size, colour, and it is
no.
the exact same thing. And some people, it is confusing when no one lets you know that, like this is the same thing, we've just got a different name for it this time.
Different company.
Yeah, so a
Same
different
thing,
company
different
makes
company.
it. Yeah, exactly.
It's like going to Coles or Woolies or Drakes.
Exactly. Yeah. So a brand name, so for example,
Paracetamol,
we could get Panamax, we could get Tylenol now. So in Australia, Panadol would be the originator. So it's the original product and they were the first people who brought that drug to Australia. So they sort of own the patent for it, for that name, which is sometimes why it can be a little bit more expensive. You've got to pay the brand price premium is what we call it. So
you can buy Nurofen in the chemist for like $15, $16 and you can walk into Coles or Woolies and get it for 70 cents.
Exactly. And so you're sort of just paying so Nurofen can keep the name Nurofen and no one can take it from them.
And do
so
their advertising and...
Exactly. They pay for their advertising, they pay to be Nurofen and they pay to be Panadol. So I suppose that's really the only difference between them, what a generic is. So when the patent runs out, a generic company, so something like Apotex or Mylan, which you might have seen, they can come in and say, we're going to make something that's exactly the same drug, we just can't call it Panadol, we'll call it something else, or we'll just call it ibuprofen, we won't put a name on it. So that, I suppose, is the difference. In Australia though, they have to pass testing that proves that they are exactly the same, so they're just as safe and they're just as good as the original brand. They can't just say...
How do they do that?
So they've got to go through rigorous testing, so they have to go through clinical trials and other testing that proves that if we say this has got 200 milligrams of Panadol in it, then it does. And it's not going to give you a side effect that Panadol wouldn't. So they go through testing like that. And often they're cheaper because they don't have to pay for advertising, they don't have to pay to keep that special brand name that everyone knows. So that's, I suppose, the difference. If anything happens like that to you, they're the two differences between a generic and a brand name product.
We'll now talk about anti-inflammatories. So anti-inflammatories belong to a class of medicines called non-steroidal anti-inflammatory drugs. The first one we'll talk about is celecoxib, which is the brand name Celebrex. So it is used to relieve pain and inflammation. The usual dose is 100 milligrams twice a day, which is a maximum of 200 milligrams a day. It's best to have these drugs with food. So the mechanism that they bind to also can increase the incidence of indigestion. So we have it with food to sort of minimize that. Some people don't really tolerate them because of that mechanism of the indigestion causing. If they've got things like acid reflux, that can be particularly aggravating. You can also get a bit more of a stomach ache and things like that from these drugs. The generics that exist are the Apotex brand that Caitlin was talking about before, Selexi, and another one called Selexib. But again, they all contain the same drug, celecoxib.
Next, naproxen, which you might see as naproxen. That is another non-steroidal anti-inflammatory and works the same as the celecoxib. So I guess you can expect the same sort of side effects with that sometimes, stomach pain, indigestion, and reflux. The maximum dose for this, so there's two formulations. So we've got controlled release, which means it's got a special sort of coating in it. So the drug's sort of not, you don't take it and you get it all at once. The coating slowly dissolves and you get that drug over a longer period of time. So you get that longer anti-inflammatory effect. And then there's also the immediate release, which means when you take the drug, sort of immediately, all that drug's absorbed into your system and you get that big hit of anti-inflammatory all at once. So when we're taking the immediate release, we'll have to have less of it because we're having more of it at once. So 250 to 500 milligrams twice a day is normally what we'd expect to see. And with the controlled release, 750 to 1000 milligrams just once a day, because as I said before, it sort of works over a longer period of time and you'd expect it to sort of last 24 hours of pain relief and anti-inflammatory properties. So the generics we have for this are Inza and Proxen, and then we've got the original brand, which is the naproxen. And again, we take this on with food just to sort of help reduce the chances of that indigestion and the reflux that we can sometimes experience with anti-inflammatories.
Another anti-inflammatory we've got is meloxicam, otherwise known as Mobic. Again, it works very similarly to naproxen and celecoxib. This one's dosing is a little bit different. It's taken just once a day and it is an immediate release rather than being a slow release formulation. That's because this drug tends to work a little bit longer without needing that special coating that naproxen needs. All of the anti-inflammatories, there's not one that trumps the other. It is very, very personal. Some people respond particularly well to one over the other. But we just thought we'd highlight a few of the more common ones that we see in AS.
I suppose just quickly something to add with meloxicam is you probably notice that the dose is a whole lot lower than what we're talking about 1000 milligrams for the other drugs, but this one's only 7.5 to 15. I guess what happens with some drugs is they're just not absorbed as well because of the structure of them and the way they absorb into our cells and into our tissues. So this one works particularly well as getting to where it needs to go. So we take a much lower dose, so you don't need 1000 milligrams, you only need 15.
As we mentioned before, some people when they take anti-inflammatory medications, they get indigestion or reflux. So commonly we see, this is a proton pump inhibitor example, Losec, sort of used concurrently with the NSAID. What these do is they reduce the amount of stomach acid we produce, so that regurges and causes irritation up here. They might not be used. They also might only be used on a when required basis. But we just thought we'd highlight it in case any of you guys are taking anything like this and have wondered why. They also can be used to prevent the development of gastric ulcers. So if you're using the NSAIDs really readily and frequently, your stomach acid can increase a little bit, and that makes you a little bit more susceptible to developing an ulcer. So these are used just to minimize that.
So those were sort of the main stays and sort of to help with slowing disease progression in AS, but there are also other medications that we can use for pain management. So amitriptyline is a tricyclic antidepressant, so not really used much for depression anymore, just because of a few of the side effects that's not really desirable. But it can help improve sleep and also helps with secondary pain. So if the
constipation, that's one thing I was going to ask about.
yeah. So it's sort of, I guess, the best way to describe the side effect profile of amitriptyline is it just dries you up. So you just can't really do much properly.
Dries a chip.
Yeah. So dry mouth, constipation, dry eyes are side effects that you might get, but it's really good at helping if you do have disease progressed so that you're in an awkward position and you're getting nerve pain. It can help with sort of the pain associated with that.
Like a neuralgia thing.
Exactly, yeah. Neuralgia is one of the main things we see it used for now. But because of the side effect profile, it's probably not going to be first line for many people. So yeah, dry mouth, blurred vision, constipation. And we start, so I suppose what we do with amitriptyline is we start low and go slow and increase as we need if we need. So we start at 10 milligrams and we can go up to about 50 if we need to. And again, we've got NDEP as the original brand, and then we do APX and also Apo do one as well.
Apo does everything.
Apo does everything, yeah.
The other one we wanted to touch on is duloxetine, or it's known as Cymbalta. This is another antidepressant, but it works a little bit differently to how amitriptyline works. So this one is a serotonin and noradrenaline reuptake inhibitor. And studies show that duloxetine is the best antidepressant for neuropathic pain. And as AS progresses, there can be neuropathic pain, so we tend to use, this would be our antidepressant of choice. But it's sort of a win-win with this one, because we know that this disease can impact people's lives and can make you anxious and can affect your mental health. So it does work as an antidepressant as well. So it can benefit sort of, stress and anxiety as well as helping with pain. As Caitlin mentioned before, with the antidepressants, they're not necessarily first line. They're sort of, used as needed. And might be added later on in therapy. And with something like duloxetine, it can have a little bit of time to onset, so people don't necessarily feel better straight away. It can take 8 weeks and onwards. So I guess the key message is, if you do
they have black box warnings?
Black box warnings?
Yeah. Like a lot of antidepressants have, like, they can make you worse.
Yeah, so it is one of those ones that can initially highlight the symptoms. If you are depressed, it can increase what they say suicidal ideation initially. It's something people need to be educated on. That's not to say that'll last forever though. So it is only in that first sort of few weeks of therapy, and then as it progresses, it eases up, hopefully. This is one of the ones that can make people a little bit dizzy and a little bit drowsy initially, again, hopefully letting up. If you are to be started on anything like this though, and you can't bear with the symptoms, don't put up with it. You don't have to stay on it. So that's sort of what we say.
Go back.
Yeah.
Go back to your GP.
Go back to your GP, exactly.
Okay, so disease-modifying anti-rheumatic drugs, or DMARDs as we call them, because it's much easier to say, are newer drugs that help to, I suppose, modify our body. So they're not like anti-inflammatories that help to stop sort of the inflammation and stop that process. They actually work biologically to stop that disease progression and slow it down. So again, there are biological medicines, which are the originator products, and there are also biosimilars. So I suppose the best way to look at this is an original and this is a generic. So biosimilar medicines, so they're medicines derived from a living system, and so may either be sourced from nature or product using recombinant techniques, which is sort of very smart people in the lab putting together drugs. So A biosimilar is a biological medicine that contains a version of the active substance, so it's not going to be exactly the same, but it's as similar as we can possibly make it, to an already authorised original biologic, which is highly similar but not identical versions of an already registered biological medicine.
So which is better?
Really, they're both the same. So they
Yeah.
do, again, have to go through TGA testing to prove that they're just as safe and they're just as efficacious as the biologic. Because of I suppose it's a bit hard to explain, but a biologic is a massive, massive molecule that actually attaches to your cells and works as if it is a part of your body. So because of how big it is and how complex it is, you can't make it exactly the same. So it's going to be as similar as it possibly can be, but it can't be exactly the same.
And it's still going to target the same mechanism that the biological originator product will, but because it's not identical, they can't call it the same thing.
Yeah, okay.
Yeah.
Needs its own name.
It needs its own name, and that's why they've gone with biosimilar.
Yeah.
One example is adalimumab or Humira. So this is the original product, Humira, the biologic medicine. It sort of works by attacking a inflammatory marker called TNF-alpha, which is the tumor necrosis factor. We know that this marker is overexpressed in AS. So if you can attack it before it overproduces, you can help to modify inflammation and disease. It specifically affects the immune system, so that might mean that your immune system works a little bit less because we know that it's attacking inflammatory markers, so it might not recognise general inflammatory markers that we might get, so people might get sick more often, essentially. That being said, it is very effective.
So these are some biosimilars that you may see of Humira. Normally, if you were to get started on Humira, you wouldn't just come in and we'll be like, oh, we'll switch it over. If you're stable on Humira, you stay on Humira. If you're new and you're happy to have a biosimilar, you may get started on one of these, either Hadlima or Hyrimoz. But again, because of the type of drug it is and because of the way it acts, it's not sort of the same as a generic and an original where we can just swap you over and it won't really matter. Once you're stable on one, you will stay on one. So, if you are to get started on one and you're happy to have a biosimilar, then these are the two products available in Australia.
The next drug we've got is upadacitinib, which is Rinvoq. Probably butchered it. Rinvoq is the only version of Rinvoq at this stage. The benefit of Rinvoq is it's an oral tablet, so you don't have to inject yourself, essentially, like a lot of the other biological medicines. And this also specifically attacks those pro-inflammatory markers that are found in AS. Rinvoq is sort of a watch this space right now. It's not used super commonly yet, but that's because it's quite new. But I expect in the near future we will see a lot more use of it.
So next is methotrexate. So this is the most common used DMARD. It's available as an oral tablet or as an injection. So it works to help control when you've got those cells that are causing inflammation and they're reproducing too quickly. It just helps to sort of slow that inflammatory process from happening. So I suppose methotrexate has a quite nasty side effect profile in that it can make you feel really crappy the day after you've taken it. So it's just a once a week either injection or tablet, but because of the way it works, it can make people feel quite unwell after taking it.
Is the tablet or the injection better or both the same? They feel crappy?
We would normally go with the tablet just because it's easier to take and that's sort of what we do. Practical. If it's easy, it's more practical. Yeah. That's what we prefer. They're both just as efficacious as each other, so they both work just as well. But yeah, most people would prefer the tablet because I think the thought of having to inject yourself is a bit mortifying for some people. But the tablet is preferred. So yeah, just once a week, and Yeah, so the dose can be split up into once or twice a day, normally taken with food to help try and settle some of that nausea that's sometimes associated with taking it. But yeah, I think that's all.
I think methotrexate, something to touch on, is it's called a cytotoxic medication, which means that certain populations shouldn't touch it. So pregnant people or, people who have other sort of autoimmune conditions where they might be susceptible to getting sick, shouldn't touch it. That's because, as we mentioned, it touches on rapidly dividing cells. So if you're trying to grow a baby, your cells are rapidly dividing, so we don't want to touch it. That being said, though, if you're taking it and you're around a pregnant person, that's fine.
Yeah.
No concern there. Some of the medications we mentioned are injections, so we just wanted to touch on Sharps safety. So you've probably seen the Sharps disposal kit around. A lot of the Humira pens have sort of a feature that auto engages a Sharps lock at the end once you inject it. So you press down on the end and then a plastic cover comes off that covers the needle, and then you dispose it in the Sharps bin. That's just to prevent needle stick injury, so you don't want to accidentally prick your finger after you've injected. Also, we just wanted to touch on not leaving Sharps, we're not disposing them in general waste. They should always go into one of these Sharps bin. When the Sharps bin is full, seal the lid, take it into your local pharmacy, and they'll be able to dispose of it as well. Also putting it sort of out of reach of kids, things like that. You'll also notice that there are Sharps bins in public bathrooms as well, so that's an option if you don't have a Sharps bin at home.
Yeah, I suppose as well, if you don't have access to a Sharps bin, if you've got like an old Milo tin or something that's just hard at home.
People do that.
Yeah, so
the jar or the Milo tin,
they're not super expensive. I think we sell them for about $7. So, but yeah, if you're out, or if you've filled up your Sharps bin and you need to dispose of a Sharps, then just as long as the container's hard and can't be poked through with a needle, then that's fine, as long as they're sort of out of access of kids and animals and other people that shouldn't be touching them.
We'll just touch now on some of the other therapy options. So Panadol Osteo. This is paracetamol in a slow release formulation. So instead of working immediately, it works over the course of 8 hours. It is very safe and it is very good for something to use consistently. It's also available without a prescription, so you can just pop into the pharmacy and get a box. I think they come in 96. So that's a big box that will last a while. There's very little side effects with paracetamol. It is safe to combine with non-steroidal anti-inflammatory drugs.
So your injectables.
And your injectables as well. So it's just a really good option as sort of just a breakthrough pain.
I suppose quickly I'll just touch on, so Panadol Osteo you used to be able to just buy from your supermarket and it was all good, but now it's been what we call scheduled up. So it's a pharmacist only medication. So if you go into the pharmacy or supermarket looking for it, you won't find it. You'll have to come to us and it's kept behind the counter. So you just have to ask us for Panadol Osteo and we'll say, yep, give you a spiel about how many tablets to take. Yeah. And then, so if you're looking for it, that's where it will be. I suppose we also just wanted to talk about the importance of vitamin B12. Often people with ankylosing spondylitis have low B12 levels, so it's important that we do get them tested regularly, as to what our GP says. B12 helps with red blood cell formulation and helping to help them mature once they come out of our bone marrow, and make sure we get good circulation and get good oxygenation of our blood cells as well. So we can get megaloblastic anemia if we have B12 deficiency, which can make us really lethargic, we'll feel really quite unwell. So yeah, just something important that we are keeping up with. If our B12 levels are quite low, we can get 3-monthly injections, but there also are tablets that we can be taking if it's just a little bit low and we need something to help keep it up.
And that message could extend to other crucial vitamins, so vitamin D, things like that, just the importance of regular levels. And I know there's a bit of a bad hype around vitamin C. Does it work? Does it not work? People can become deficient in vitamin C, and it can sort of make you also feel a bit rubbish. So just the importance of regular levels and making sure everything's
are very acidic on your teeth.
The vitamin C, yeah, they are.
On the temperature tanks.
Yeah.
I have tried to make tablets without the ascorbic acid, which was what was really acidic and sort of made them yummy. But so you can get them with ascorbic acid or without. So.
Oh, they do that.
Yeah.
Do you actually need a script to get a vitamin B12
No,
injection?
so that also is Schedule 3 and pharmacist only. So if you tell us sort of, that you relate to that information, like my doctor's told me I've got to inject every 3 months or I've got to inject this period of time, we can say, right, you know how to inject yourself, you know how to dispose of your sharps safely, as long as your GP knows what you're up to and we feel like you know what you're doing and you're able to inject yourself, we're able to give you a box of B12.
What about vitamin D? You said you can have that injected.
Sunshine, go and sword.
Vitamin D more commonly is just a capsule every day, but it does exist as big concentration formulations that you have every 3 months. You do need a script for those from your GP, but you get one, I think it's 100,000 units every 3 months. Mm-hmm. It's like in a little syringe, you can squirt it on toast or just squirt it in your mouth, and then you don't have to take a capsule every single day.
But we don't inject vitamin D, we just consume it.
We just consume it.
Drops as well.
There are drops.
Yeah.
And they always leak.
Yes.
Oh, okay.
Yeah, so vitamin D comes in once a day tablet, once a week tablet. You can get it 3 monthly, or you can get those drops and you can decide how often.
That's what I need.
Yeah.
Because I've got the B12 needles and I do Humira,
Mm-hmm.
and they all seem to work. I've had the methotrexate, that was no good for me, and the what was the other one? Adimba, whatever it was.
Oh, that's
The
Adalimumab.
one's antidepressants in it.
amitriptyline.
Yeah.
So I just work harder and I keep myself focused.
Yeah.
Try to think positive, and that seems to work.
Yeah. And it's tricky, isn't it? Like something works for someone and you hear great things and it's like, well, it doesn't work for me. Like, and everyone's so different and so unique, and the disease.
We need to remember that.
You do,
tailor and individualise.
Exactly, and it's hard, isn't it, to sort of see something working for someone else and you think, well, why is it working for me? And everyone is so different, and diseases affect people so differently. I suppose, other genetic makeups that we have and other things affect us as well. So I suppose finding what's right for you is what we're trying to help you with here. I think that's sort of it from us. We've sort of just spewed information at you. So
It's really good.
Yeah.
Thank you.